All right. Good morning, everybody. Welcome and thanks for joining us this morning for the Oregon Health Policy Board's educational webinar on the Healthcare Market Oversight Program. The team is going to talk about the program, legislative background, how it works, and go through an example of a recent review the program has completed. I'm filling in for Tara Chetak, the board project manager. And before we start, just a couple of housekeeping items to cover. Today's educational webinar is for informational purposes only. Oregon Health Policy Board business will not be conducted. Today's webinar is being recorded for board members, staff, and guests who are not able to join us live. The recording will be posted on the Policy Board's website under today's meeting date. During the webinar, we are going to put everybody on mute and we'll take questions in the chat throughout the webinar. You can raise your hand in the Zoom features, or you can send a chat and we will address the question as we go. We're going to stop periodically as we go through each section. We'll also have time at the end of the presentation for additional questions. All right, so to start, next slide, please. Ali Hassan, the Interim Director for Health Policy and Analytics, is going to provide a few opening remarks to frame up the program and today's webinar. Ali?
Well, thank you so much, Sarah. It's really nice to be here with everyone. Sarah mentioned my name is Ali Hassan, the Interim Director of the Health Policy and Analytics Division, and also the Director of PEB and OHPB. And I use he, him, his pronouns. I'm really excited to be here to kick off the webinar in our Healthcare Market Oversight Program, better known as HCMO, HCMO. We have assembled really an incredible team at HCMO, and I'm really excited for them to report on the great work that they have been engaged in. This webinar will provide an overview of the statutory purpose of the program and the rules governing the review of proposed business deals between healthcare entities. Goals of the program include ensuring mergers and acquisitions support statewide goals related to health equity, lowering costs, increasing access, and improving quality. Also promoting transparency so communities are aware of planned transactions before they happen and can provide input. And then lastly, monitoring trends in healthcare consolidation and assessing how transactions impact people across the state. Very important things. These goals all align with OHPB's strategic priorities, supporting policies and programs that center health equity and contain healthcare cost growth. Today's webinar is an opportunity for board members to learn a great deal about this body of work and how it further relates to the board's priorities. So with that, I'll hand it over to the HCMO team to kick off the webinar. Thank you so much.
Thanks, Holly. All right, next slide, please. Just to introduce the HCMO team to everyone and let you know these are your presenters for today. So I'm Sarah Bartleman, I manage the program. We also have Jenny Grunditz, who's our lead policy advisor, Stacy DeLong, policy analyst, Chandra Elser, research analyst, and Zachary Goldman, healthcare cost economist. So we're all going to take a little section of today's presentation and you'll get to hear from the whole team. And next slide. And finally, I think as we've already said a couple times now, we're going to start talking about consolidation in healthcare and why we have this program. We're going to talk about the program itself, and then we'll talk about our review of a transaction. So with that, Jenny, it's all you.
Hey, thank you so much, Sarah, and thank you, Ali, for the introductions. Excited to be here today. So if we can go to the next slide. As Sarah mentioned, I'm going to talk about consolidation in healthcare and why it's important to pay attention to. So the next slide, please. So first of all, just some definitions around consolidation. Consolidation means when two or more companies combine, and that can occur through a variety of different types of business deals, such as mergers, acquisitions, joint ventures, partnerships, or affiliations, or other. This is not an exclusive list. Then in healthcare, when we talk about consolidation, obviously that involves healthcare entities such as hospitals, insurers, clinics, health systems. Can also involve other companies that are, not traditionally, have been involved in healthcare but are entering the healthcare space. So can we go to the next slide, please? So we typically distinguish between horizontal and vertical consolidation. Horizontal consolidation is between companies that offer similar services or products, and this is what we typically think about when we think about consolidation: is one hospital merging with another hospital, or one home health provider acquiring another home health provider. But there's also vertical consolidation, which is becoming increasingly common in healthcare, between companies that offer different services or products, or if you can think of them as being at different levels of the supply chain. So, for example, a hospital system that is acquiring a group of physicians, or an insurance company that is acquiring a hospice provider. And so if we can go to the next slide. There's also increasingly in healthcare in the US, consolidation that involves entities that operate in different geographic markets. And so different states or different regions, and we call this cross-market consolidation. So you can have a hospital system in one state that is acquiring a hospital or facility in a state where they previously have not, been present. So that is an increasingly common trend, and we're seeing some really big deals recently, just this year, that have been cross-market. And if we go to the next slide. So briefly, just wanted to kind of summarize what the research has found on consolidation in healthcare. There's been quite a lot of studies looking particularly at horizontal consolidation, but also vertical, and then more recently looking at cross-market consolidation. And generally, the general finding across a number of studies is that consolidation is associated with higher prices for products and services, and higher insurance premiums. And this makes sense from a theoretical perspective. When companies have a larger market share, they have market power, so to speak, which means that they are able to set prices higher, and still make a profit, and it's profitable for them to raise their prices. Secondly, the research generally points to consolidation not being associated with any improvements in quality or outcomes. And this is often, a stated purpose of consolidation, where companies or healthcare providers are saying that they are going to improve quality and efficiency and so forth. But generally, the evidence has not sort of borne that out. And in some markets where there is not a lot of competition and not a lot of alternative providers, we've actually seen that that outcomes or quality gets worse. And thirdly, obviously, consolidation involves changes in services. So it can involve changes in the type of and location of services, staffing, as companies integrate and merge their operations. And this can lead to have impacts on both kind of access to care and also quality, or quality as well. But I was specifically going to point out equity here. Studies have looked at consolidation involving rural hospitals, for example, and found that in those cases, it's actually, there have been several studies that have found that rural hospitals tend to close services if they're part of a merger or an affiliation, particularly services that are lower margin. So certainly it can also, I see Pat is mentioning that it can also be a way for services to be maintained if there's a provider that is in a financially precarious situation. So that can also cut both ways. But generally, based on what we've seen in the research, this is happening in some cases in rural hospitals. And so let me go to the next slide, please. Another important trend to note in consolidation in healthcare is that private equity deals are becoming increasingly common. We've seen in the last 10 years, private equity, the number of deals has more than doubled in the US, and these are nationwide numbers. And for those of you who are not familiar with private equity, just briefly, these are firms that invest in or acquire other private companies. They raise funds from third-party investors such as retirement and pension funds, and they generally don't hold on to companies for very long, approximately on average between 3 and 7 years. And during that time, the focus is generally on generating profits and maximizing profits in the short term to benefit the investors. And so if we go to the next slide. Private equity ownership has impacts for how care is delivered. We're seeing increasingly reports in the press and also increasingly in research looking at the effects of private equity ownership in healthcare. And this is an example here of a study that was recently published that found that private equity ownership of physician practices across the country was associated with higher charges and more utilization. And then we can go to the next slide. Okay, so changing gears a little bit and looking at Oregon specifically, just wanted to highlight a few data points that we have currently for Oregon and specifically for the Portland metro area. So in Oregon, most hospitals, as you probably know, are affiliated with or owned by health systems. And this has increased in the last decade or so. In 2003, 43% of hospitals in Oregon were independent, whereas by 2020, only 25% were independent. And in the Portland metro area specifically, we have some data on physician employment by health systems. And these are some data points from 2016 and 2018 showing that there was an increase in the percentage of physicians working for health systems from 39 to 71%, just the space of 2 years. Unfortunately, we don't have any further updates to that data at this time. And then another important fact sort of to be aware of in Oregon is that relative to other states in the country, Oregon's insurer market is not highly concentrated, meaning that there's relatively many insurers that are active in Oregon, and they each have a relatively, well, I'm talking in relation to other geographic markets in the US, they have smaller shares of the market. And that means that they, in combination with on the provider side, where you have large providers that have a lot of negotiating leverage, that tends to lead to upward pressure on prices because insurers have to, they may have to accept higher rates in order to have a provider that is considered essential or sort of a must-have provider in their network. And so we'll go to the next slide, please. So what does all this mean for people in Oregon? Obviously, higher healthcare prices means higher personal spending on healthcare. And if folks can't afford healthcare, they will forego care or medications. They may have to take on medical debt. For employers, increasingly healthcare costs are growing rapidly, and this means that they are not able to raise wages at the same pace that they may have otherwise been able to do because they're paying more for insurance premiums and insurance costs for their employees. Obviously, if there's consolidation, that means that you may have fewer options for care. You may just have a couple of systems that you have to choose between in your area where you can obtain hospital services, for example, as a patient. So, and then if you're a physician, you may have fewer options for where to go for work, where to work, and may not be able to, may not have the option to maybe work for a smaller independent practice, rather having to go work for a health system, which can be great, but also, you know, there's that's a different environment, and so that can have implications for physicians and other medical professionals. And then just wanting to point out that these effects are not generally felt evenly across communities or across populations, and they can generally exacerbate health inequities. And so if we go to the next slide, I just have an example of that, showing that, and this is not necessarily related to consolidation, but just looking at what happens when costs increase and people forgo care. This looks at, this is data from the CDC that shows Oregon residents who needed to see a doctor in the last 12 months, but could not because of costs. And we see that those folks are not evenly distributed across racial and ethnic groups or levels of education or age, and more likely to be folks that are Hispanic or Black or multiracial, and folks that are younger and have less education. And lastly, I have one more slide to share, which just shows as of February this year, that medical debt in collections in Oregon, approximately 5% of people had medical debt in collections, and the gap between communities of color and white communities was quite significant. 12% of folks of color had medical debt in the survey, compared to 5% in white communities. And this gap was actually larger than the national gap between these two groups. And with that, that is the last slide that I have. But yes, I see there's questions. Go ahead, please, Pat.
Yeah, not a question, but I just wanted to quickly amplify the slide that you talked about in terms of insurance consolidation, because it's so counterintuitive. People ordinarily are tempted to think, well, if you're buying insurance, having lots of insurance companies is good because you can pick from amongst insurance companies. But if the market you care about is purchasing the healthcare, it's the insurers that are purchasing the healthcare, and the more of them there are, the less concentrated market power they have. So if they need the providers have the leverage to drive higher prices. If there are fewer insurers, then the providers need the insurers or the payers, and it changes that dynamic. And again, that's really counterintuitive, and I think is worth kind of drilling in on.
Yeah, thank you. I see John Santa has his hand up.
Yeah, a couple of comments. I think your graph about private equity is really interesting. I wonder, your comment was that those groups are in private equity kind of as a transition to get them ready or get them more profitable. And I think it would be interesting how many of them end up in publicly traded companies. I think publicly traded companies, when it comes to healthcare, are especially worrisome because those companies are driven by quarterly reports, but they're driven by their stock market price. And they really are under pressure to be profitable in the near term. And my own opinion is what's worrisome is these private equity groups are going to end up in publicly traded companies that are unstable. The other comment as I listened is, we've had decades of problems in the provider community as a result of consolidation in certain specialties. Like anesthesiology, oftentimes hospitals are over a barrel. They have one group of anesthesiologists who does all of that for them, and that group becomes incredibly powerful. In Portland, I believe we still have one group of anesthesiologists who do 90% of the anesthesia, it doesn't take a genius doctor to realize, wow, those guys are doing really well compared to those of us who actually kind of compete. I know there's been some specialty consolidation in Portland also, and back in the day when I was involved again, the degree to which specialists in a community would consolidate, as I think Pat kind of just mentioned. You'd wake up one morning and they were in charge of the community from an economic point of view, because you either met their expectations or things got very unpredictable. And
Yeah, John, John, thank you for sharing both of those perspectives from the provider. I'm going to cut your comments off a little short because I want to move to Zachary's section. And I think you're providing a really great segue of some of the legislative intent behind the program and the things that the program is charged with looking at. So thank you. And I'm going to keep us moving.
Great. Thanks, Sarah. And thanks, John and Pat and Jenny for teeing all this up. Let's move to the next slide. So what we've covered thus far is consolidation, both in a conceptual level, also national level, and in Oregon. Let's move to the Healthcare Market Oversight Program itself and how it's designed. So through this HCMO program, the Oregon Health Authority reviews proposed healthcare business deals, transactions, to make sure that they support statewide goals related to 4 domains: cost, equity, access, and quality. And you're going to see these 4 domains throughout the rest of this presentation because this is the kind of foundational pillars. Broadly, there are kind of 3 specific aims of the Healthcare Market Oversight Program. One is to promote transparency. So OHA posts and publishes the notices of material change transactions. So when entities are going to transact or they're planning to transact, they complete a notice. We post that. OHA also publishes reports on a given transaction so that communities are empowered with information about those planned transactions. Secondly, there are statewide priorities that HCMO supports, namely to ensure that healthcare deals support these goals related to affordable care, eliminating inequities, right, cost, quality, access, equity. And then thirdly, monitoring and studying the impact. So not only does the program track deals in the state and evaluates how these specific deals are going to affect people in Oregon, but the program also produces reports on the impact of healthcare consolidation generally in Oregon. Let's go to the next slide. And HCMO aligns with some specific Oregon Health Policy Board priorities. There are strategic priorities related to health equity and cost growth containment that were outlined in the OHPB approved HCMO guiding principles and framework. Now, this is a year ago, almost exactly a year ago. And specifically, the Oregon Health Policy Board said the program should focus on the health of people living in Oregon. The program needs to ground all analyses and the impact to health equity, access to care, quality, and costs. The program needs to meaningfully engage the public and stakeholders in a robust, transparent process, which could include the creation of a stakeholder review board. Now we call it community review board. And lastly, use resources wisely, because there are potential cases in which there's a transaction being reviewed by both OHA and the Department of Consumer and Business Services, and potentially the Department of Justice, when applicable. So to use resources wisely, coordinate and align those efforts. Let's go to the next slide here. So just to keep it at a high level here, the HCMO program supports OHA's goals to eliminate health inequities by 2030. And there are 4 specific areas of this. One is how the program is designed. Right out the gate, and even in statute, frankly, the program kind of roots all analyses in health equity and ensures there's a connection point between the program and communities. Secondly is just data and analysis. When we review a given transaction, we're looking at claims data, financial data, and when we can, particularly in the claims area, we stratify that data by race, ethnicity, language, disability. Hopefully, at one point when we have the data, sexual orientation, gender identity data, we can't do all of those stratifications currently, but we have a goal to do so. And community and public engagement are key. And then, as I mentioned before, reporting and publicly notifying communities when a transaction is occurring. Let's go to the next slide. So just some background for kind of a little history here. The HCMO program was created last year by House Bill 2362, passed the legislature. There was an initial planning and rulemaking period, and then the program officially launched and started reviewing transactions this past March, so March 1st of 2022. On our website, which is linked here in the slides, we have guidance documents, instructions for entities on how to fill out a transaction notice, information on current reviews that there are no current reviews currently, but when there are, we post that, as well as completed reviews. At the bottom there, we have some links to the statute and the OARs, the administrative rules. Let's go to the next slide. Let's kind of take it up a notch here and look at where Oregon is relative to other states, because Oregon isn't the only state that has a program that reviews proposed transactions, but Oregon has one of the strongest market oversight programs in the country. There are some states that are starting to build the program, namely California, but there are a number of other states that have something at least similar or maybe even closely related to what we do. Connecticut, Massachusetts, and a handful of other states have some kind of oversight. Here we have a color scheme here. Which ones have a stronger review? Which ones maybe have a less strong review? But Oregon isn't alone necessarily, but we do have one of the strongest market oversight programs in the country. Let's go to the next slide. So again, just to focus on these 4 domains because they're so key to what we do and how we do it on the program here. Every transaction that we review, we look at it through 4 domains: the cost to consumers, access to services, health equity, and healthcare quality. And as Pat kind of texted before, sometimes these things can go in different directions. It's not necessarily true that consolidation every transaction is going to drive up cost. Every transaction is going to reduce access. That's not necessarily true, but we need to look at each transaction in its community, what's entailed in the transaction, and assess these 4 domains. And sometimes costs could decrease potentially. Sometimes access could increase, but we have to get into the specifics to understand that. Let's go to the next slide. So the culmination of this entire program is that there's a decision reached for a given proposed transaction. And so the authority that OHA has for this program is one of 3 outcomes. 1, an approval of the proposed transaction. 2, an approval with conditions. If there are certain kind of concerns or red flags that the authority is seeing in a given transaction, we could approve it, but with certain conditions being met. Or after a full comprehensive review, which could take up to 6 months and could potentially even involve a community review board, the authority could reject a proposed transaction. So those are the 3 outcomes of the review. And for transaction involving any kind of acquisition of a domestic health insurer, so a carrier, technically OHA doesn't decide the transaction. But we provide a recommendation to the Department of Consumer and Business Services because they are the regulator of domestic health insurers. So OHA would make a recommendation to DCBS, and then DCBS would be the ultimate decision maker on that front. Let's move to the next slide. And with this, I'm going to pass it over to my colleague, Stacy DeLong, who's going to talk a little bit more about the program mechanics and how it, who's subject to review, and under what criteria.
Thanks, Zachary. So first we'll talk about what entities are subject to review. Our statute lists some specific healthcare entities such as hospitals and insurers that are included in the program. And it also defines a healthcare entity. It does so as any entity that has a primary function of providing healthcare items or services. So this would include things like pharmacies. It includes parent organizations of entities that provide healthcare items or services. This could include something like a private equity firm that has a significant ownership stake in a provider group. And it also includes entities that are closely related to an entity that provides healthcare items or services. And this could include something like a management services organization or dental support organization. I'll note that we have guidance on our website that clarifies and further lists entities that HCMO considers to fall within this definition. Next slide, please. So we'll talk about what transactions are subject to review. The first question we ask is it material? And this is basically about whether the entities have enough average annual revenue to meet the thresholds for our program. So one entity must have average annual revenue of at least $25 million in the preceding 3 fiscal years. And another entity has to have average annual revenue of at least $10 million for the preceding 3 fiscal years. In the case where there's a new entity that's being created, that entity would have projected to have at least $10 million in revenue for its first full year of operation. If a transaction involves entities that don't meet these thresholds, then it's not required to submit a notice. And I'll also note that it's up to the entities to determine whether they're required to submit a notice. They can ask OHA to make a determination, but generally the entities are using guidance from OHA to determine whether or not they need to submit their notice. Next slide, please. The second question we look at is whether the type of transaction is one that HCMO covers. So if it's a merger, acquisition, or corporate affiliation, they have to submit a notice. If it's a new contract or affiliation that will significantly reduce or eliminate essential services, they have to submit a notice. We also have guidance on our website that defines what we mean when we talk about essential services and significant reductions. But in a nutshell, essential services include services that are on the prioritized list, that are directly related to the treatment of chronic conditions, that are pregnancy-related services, prevention services, and/or care coordination and health system navigation services. And for significant reduction, generally we're talking about that is a decrease in the number of providers or services by more than 1/3. It's also covered if it's a new partnership, joint venture, accountable care organization, parent organization, or management services organization that will eliminate or significantly reduce essential services, consolidate or combine providers of essential services when contracting payment rates, or consolidate or combine insurers when establishing health benefit premiums. For those last 2 bullets, we're really looking at if it's changing the negotiating power of providers or payers. Next slide, please. So this slide is looking at our high-level review process. The first step is always for entities to let us know that they're planning a transaction. This involves filing a notice using the forms and instructions that we make available on our website. Our staff also provides technical assistance and guidance to entities prior to and during their filing. OHA conducts a review to understand potential impacts of the transaction. The first part is we'll do a 30-day preliminary review. If we determine the transaction raises concerns, requires deeper analysis, we may do a comprehensive review, which needs to be completed within 180 days of filing. We get public input for all of our reviews. So for a 30-day preliminary review, we'll accept written public comments. For comprehensive reviews, we'll also have a public comment period, and we may convene a community review board, which I'll talk about on the next slide. After completing reviews, we issue an order to approve with conditions, or reject the transaction. We can also exempt a transaction if, when we receive the filing, we determine that it doesn't meet coverage or materiality requirements. Next slide, please. So for our comprehensive reviews, we can convene community review boards. And these are groups made up of people who live or work in affected communities and can include patients, consumers, health insurance plan members, interested residents, healthcare experts, and advocates. According to our statute, no more than 1/3 of community review board members can be representatives of institutional healthcare providers. Community review boards will provide a recommendation to OHA about whether to approve a transaction. They may also provide information and contacts to help us understand the potential impacts or fill gaps in our data. And then community review boards provide an avenue for community members to influence decisions about healthcare in the places where they live and work. I see that there's a question. We do have a slide about that, so I will get to that, and then let me know if it doesn't, we don't address it. Okay, so we also conduct follow-up reviews. These happen 1, 2, and 5 years after the transaction closes. for all the transactions that we've approved. And really what we're looking at is what has happened since the transaction closed. So we want to know, and our statute directs us to do these follow-up reviews. And in the statute, it directs us to look specifically at how well the entities have complied with any approval conditions, if there were approval conditions, the cost trends and cost growth trends for the entities, and the impact of the transaction on the cost growth target. The statute directs us to incorporate follow-up review findings in cost growth target reporting. So this kind of creates a strong link between those two programs. In our follow-up reviews, we'll also look at how well the entities stuck to any commitments they had in the notice. So for example, in the notice, if they committed to keeping certain facilities open, we look at, did they do that? And we also look at any impacts to services, any impacts on access to services, quality of care, or equity. Next slide, please. Okay, so in the 9 months that the program has been live, we have completed 4 material change transaction notices. We completed 30-day preliminary reviews for 3 transactions. These involved a transaction with Kindred at Home Hospice, Humana, and CD&R, which is a private equity firm. We completed a transaction, a preliminary review for United Health Group's acquisition of LHC Group. And we also had a review of a transaction involving the changing private equity ownership of Specialty Dental Brands, which is a dental support organization. We approved all 3 of those transactions. We also received a notice related to a transaction involving Advantage Dental. We exempted that transaction from HCMO review because it had already previously been approved by OHA. The transactions we reviewed involved patients living in 21 counties in Oregon. So there's a map here, and this is based on the service areas of the provider locations, and we calculate that based on where patients of those providers live. We'll also be issuing an annual report soon that includes more information about what we've done since the program has launched and what we anticipate in the future. I'm going to pause briefly to see if there's any questions or comments. Okay.
Not seeing any more questions in the chat, so let's keep going.
Great. I'm going to hand it off to Chandra for the next set of slides. Thank you.
Okay, in the last few minutes here, we can do the short version of our review of United Healthcare's acquisition of LHC Group. If we could go to the next slide, please. So this is a proposed acquisition from United's Optum arm, which is their provider branch of the large organization that is United Health Group. And they purchased LHC Group, which is a national provider of home health and hospice services. They operate in 37 states. So this is one of those cross-market transactions that Jenny had mentioned earlier. There are 9 locations located in Oregon. Because it is an insurance company purchasing these provider networks, it's also a vertical consolidation. Next slide, please. The LHC locations served patients across 12 Oregon counties. So there's a concentration in the Portland-Salem area, in Bend, Lapine, Medford, Grants Pass, and then La Grande and Baker City. And the map here shows, again, those areas, the footprint where patients who utilize those providers reside. So it's not the entire county, maybe a couple of zip codes in that county, but residents in each of those counties were affected by this transaction. Next slide, please. So in doing our review, the focus on equity was a little challenging. We're still trying to figure out how we look at equity given some of the absence of demographic data that we see in our administrative claims data, and the publicly available data that we look at from CMS or other places is not always disaggregated by demographic information. And so we turned to literature reviews to identify where we see equity challenges in home health or hospice. There was really an interesting insight into differences in experiences from the patients of these services as well as caretakers of those patients. So our report identifies a lot of general equity concerns that we have seen across the country from the literature, but there was nothing specific to this transaction that caused us to have any concerns. We will continue to monitor for those things as we do those follow-up reviews though. And we will ask for some more specific data that is disaggregated by some of those key demographic characteristics. Next slide, please. In looking at cost, there was not necessarily there's no horizontal consolidation, so there wasn't a concern about cost changes from that perspective. Medicare is also the dominant payer for home health and hospice services that we see here in Oregon. And because some of those prices are relatively fixed, there's less of a concern for any possibility of pushing on prices from that perspective. So we sort of deemed this transaction unlikely to significantly impact healthcare costs in the state. Next slide, please. And for access, there was no indication from United that they were going to close or consolidate any locations. Most regions that we looked at have other options for home health and hospice services. And so LHC did not have a dominant market share in most places, except for in the LaGrange and Baker City area. They're sort of the only shop in town, and folks there would need to drive 75 miles or more, often into Washington State or into Idaho in order to find additional services. So that is one area that we are paying attention to as far as any sort of changes to quality of care or access in that particular region. One concern we did have is just noting that as an insurance company purchases a provider network, we want to make sure there isn't preferential access to that provider network being offered only to people who have that insurance coverage. And United did make commitments in their notice not to do that. And that will definitely be something that we continue to monitor in those ongoing follow-up reviews. Next slide, please. And on quality concerns, there were really no concerns that we had of existing quality at any of the LHC locations. And United is really interested in creating some value-based payments and folding LHC into their continuum of care and focusing on transitions into home health and hospice. And so if anything, we have some hopes that quality might improve under their ownership. But there is an ongoing federal review of this transaction, and they were really focused on potential labor market impacts and staffing. Those staffing ratios absolutely have impacts for access and quality, and so we'll continue to monitor what that federal review discovers from this transaction. We will continue to look for those things in our ongoing follow-up reviews as well. Next slide, please. So given all of those things, we decided to approve this transaction because it met the criteria laid out in our statute to do so. So it was unlikely to substantially reduce access to healthcare and unlikely to alter the delivery of healthcare here in Oregon. Next slide, please. Okay.
All right, thank you. We have caught up on timing, so we have a few minutes for questions or comments. Open things up to board members. Anything that we can clarify, anything that's caught your ears and eyes as we went through this presentation.
So just representing Eastern Oregon in the LaGrange Baker area for access and so forth. When will that review be out, or how many, do you do it every quarter, every month, on any summaries that show any inconsistency in healthcare for patients?
Thanks, Sandy. Chandra, do you want to take that one?
Sure. So the required post-transaction reviews that we do are 1, 2, and 5 years after the transaction. It often takes some time in order for the impacts of a transaction to show up in the data. And then in addition to that, we also have data lags. So a quarterly review of that, I don't think would show us information, but we will certainly be paying attention to that at the first year review. And it's not likely that some of the data that will actually show impacts to access will come until the second or the 5th year review.
So you were stating though that depending on the insurance requirements, they had stated that they would not use that as a factor. But if you see more patients going to Boise area or Ontario and possibly Walla Walla, then how do you guys review that then if that is occurring and you see more patients looking elsewhere for healthcare services?
I can take a start at that one. I think in the reviews, we would certainly look at where patients are going and where residents in those affected communities are going. So Chandra was presenting some of the maps and patients and talking about the market concentration and, of all the patients in a given county or zip code who accessed home health services, which providers did they go to and where? So we will be able to monitor if that's changing over time. I think in these follow-up reviews, which we haven't done yet, right? Reminder, we only launched in March, so we haven't rolled through to doing a full follow-up review yet. So some of this is just our intention and is definitely subject to change, and we're open to some feedback from board members too. We would want to repeat some of those analyses to see what has changed. We would want to do some new analysis to see what to follow up on some specific questions that might have been raised. And we will want some sort of opportunity to have public comment or to hear from community members in those affected areas. So patients of a facility or of a provider, and really incorporate that perspective in the follow-up reviews as well.
So you'll be able to monitor due eligible patients and then just Medicare patients for services
Yes.
through your data. Okay.
Yes. All right, John.
Yeah, very interesting work. I think in a previous session, we expressed concern that this activity was going on in an area that specifically focuses on an extraordinarily vulnerable population, people who are dying. And, it just makes me uncomfortable that you've got private equity, for-profit folks who are actually coming into an area with vulnerability. I would caution, while I think it's terrific you're looking at this from a race and ethnicity point of view, that there's many other discrimination aspects that could be possible here.
Sorry, we didn't cover this in the presentation, but I think if folks haven't had a chance to look at the review report, it is very rich. We look at the patients by payer, we look at a number of different factors. So I think, John, I'm going to guess that part of what you're talking about is the differences between folks on Medicare and those with other types of insurance or those who are uninsured. And that is something that we are looking at in reviews. So just wanted to mention that explicitly.
Yeah, that's great. I'm also concerned, Sarah, that within Medicare, Medicare Advantage, there is a lot going on there. And there is a lot of interest in private equity and publicly traded companies and in United Healthcare in the Medicare Advantage market. Now it may be a reasonable thing that this kind of acquisition gives United Healthcare a entree, if you will, into some markets that could be advantageous to them from a Medicare Advantage point of view, or from a value-based payment. Medicare goal is to move people to value-based payment. Not everybody thinks that's a good thing. There's a lot of us in Medicare Advantage plans, especially this time of year when all the advertising is going on, that are wondering, what's going on here? And what's behind all of this money moving around? And it's big money. When you're talking about Medicare, it's big money because we have much higher per member per month costs, if you will, and allocations of resources. So I don't disagree with the decision. I just want to bring those things up.
Yeah, thank you for that. And I think in some cases, these are really tricky questions. This is a potential impact, a projected impact. What is the likelihood of some of these things happening, and what sources and what pieces of information are we pulling in to make those determinations? So yeah, I want to talk about one more aspect of the program that I don't think is, we didn't sort of explicitly call it in the process, but as part of the monitoring the state of consolidation in Oregon, as part of monitoring and doing any of these individual specific reviews, that we are pretty closely tracking what's happening nationally. So this is a growing topic. This is of growing interest. You've probably seen any number of headlines, stories. I'm dropping the link to a new piece that came out yesterday from Kaiser Health News on private equity in healthcare. This is a growing body, and that's something that we're really closely monitoring. Various federal agencies are getting involved in different ways, and we really want to make sure that any of our reviews or our determinations are coordinated with that, and that we are learning from and benefiting from that emerging research and that focus on this, because this is definitely everything you're saying about the concerns and the potential risks is part of the national conversation here. Okay, we are just about at time. Any other board members, questions or comments this morning? Not seeing any hands. Any of our other guests, members of the public, any quick questions or comments? All right, uncomfortable silence. I'll wait you out one more minute. All right. All right, thanks everyone for participating. The webinar will be posted online, and you can follow along with our program on our website with our reviews, notices, and we will be continuing to bring an update to the policy board. So part of your monthly meeting packets going forward will be an update on reviews and transactions that the HCMO team is doing, and we would be happy to come back and talk about any of this in more detail with the board at a later date. All right, thanks so much.